This is Michael Taylor. I'm an intensivist and chief medical officer in a community hospital in the suburbs of Cleveland, Ohio. And today we're going to talk a little bit about IV fluid management and electrolytes. Our objectives are to describe the composition of common IV fluid solutions and talk about strategies for appropriate IV fluid choices in inpatient conditions. We'll talk about some routes of access for administration of fluids and spend a little bit of time on strategies for correction of electrolyte derangements. So we'll begin with a review of general physiology, leading into the content of the various IV fluids, moving on to electrolytes, and then lastly finish up with the routes of access. So to start with normal physiology, you're used to looking at this. As a clinician, you're looking at metabolic panels that have some combination of these parameters in them, and typically all of these. Seeing that sodium in the 140 range, potassium in the around 4, chloride around 100, and so on and so forth on down the line. And that's the intravascular space. The interstitial space reflects that and is essentially identical. Intracellular is different, and rather than having high sodium and low potassium, it's the opposite. It's low sodium and high potassium. And you see a lot more variability depending on cell types of specifically what's in there. I like to think about this a lot because when we measure labs, we're looking at the serum space, and that doesn't necessarily tell us what's happening intracellularly. So we're able to peek into that window of the intravascular and interstitial spaces and try to use that to help affect what's happening inside the cells. Now, the total amount of body water is pretty straightforward, about 60% of total body weight, and broken down into about 2/3 of that is in the intracellular space, and about 1/3 in the extracellular space. And of that, a similar breakdown between the interstitial and intravenous space, so around 2/3 to 1/3, 3/4 to 1/3, somewhere in that general vicinity. So taking the infamous 70 kilo individual, about 42 liters total water, with 28 liters being intracellular, 9 being interstitial, and about 5 liters in the intravascular space. And when it comes to the constant movement of those electrolytes, you're constantly losing sodium and potassium in water, typically in urine, stool, and sweat. And sodium losses typically run around 1 to 2 milliequivalents per kilo per day, with potassium losses being about 1/2 that. The water losses can be variable, but kind of generally in the range as you see there, around 12 to 15 milliliters per kilogram per day from the urine, 3 per kilo per day in the stool, 1.5 per kilo per day of sweat, and then about 10 milliliters per kilo per day from the respiratory exhalations. Now, if the patient has a fever, that sweat and respiratory losses can increase by about 8% per degree of fever or more. A little bit about some abnormal physiology. Some of the common equations used to sort of assess what's happening with fluids and electrolytes you see there. So the base deficit, something commonly used. We're lucky that with the electronic health record, a lot of this stuff is calculated for us. Particularly the base deficit is fairly commonly reported out with arterial blood gases. The serum osmo, as you see there, and oftentimes you can just kind of eyeball it. If the sodium and or glucose and or BUN are high, you can pretty much estimate that the osmolality where that's going to be. The anion gap used very frequently for any kind of metabolic acidosis, but in particular we think about it a lot with diabetic ketoacidosis. The sodium deficit's a tougher one, but kind of guessing at what the total body water is based on the patient's weight, and the desired serum sodium, and you don't know what's happening intracellularly, but for sodium deficit, there's not much intracellular sodium, so presumably isn't going to be that big of a factor. And then the free water deficit, again, is just kind of a ballpark figure using the patient's weight and their current serum sodium to make some assessment of how much fluid replacement you might need. So the practice of prescribing IV fluids is somewhat cryptic, and in many medical schools isn't really taught in a systematic fashion. It's just one of those things you're sort of expected to pick up along the way. And there's not a lot of data around it. It's, we talk a lot about evidence-based medicine, but when it comes to IV fluid prescribing practices, there's not a lot of clinical trials out there. IV fluids are cheap. Nobody's going to make a lot of money off of IV fluids, so they're not going to spend a lot of money to study it. So it's based on kind of historic and anecdotal experience, and most of us tend to prescribe IV fluids because that's the way we were taught in school and residency. Trials are difficult because just heterogeneous patient groups and comparing different types of fluids and different volumes and rates of administration, very hard to design studies that would have any kind of that we'd be able to draw any kind of meaningful conclusions from. So we don't have a lot of data, not expecting to get a whole lot of data, so we're left with, what do we think and what seems reasonable, and how can we use our intellect to make some reasonable assessments. But what's become clearer and clearer is IV fluids probably should be part of some sort of protocol to give us some guidance of what sort of fluids to be using, but probably more importantly, to help prompt us to reassess it and get rid of those fluids when they're not needed anymore. And then that IV fluid management plan needs to be reviewed daily at a minimum. When you're in resuscitation mode and using IV fluids to resuscitate a patient, then it's minute by minute essentially, and hour by hour, with maintenance fluids again at least daily at a minimum. So, colloid versus crystalloid. There's a lot of data over the years comparing the two: isotonic crystalloid, so normal saline, or Ringer's lactate versus albumin, and the general consensus is kind of no difference in outcomes, okay? But colloid is more expensive. Some data suggesting that in sepsis, albumin may be beneficial, certainly not widely accepted at this point, but some people are starting to lean that way. And then the opposite in neurocritical care, with a patient with known or suspected increased intracranial pressure. We really want to avoid using albumin because it may worsen that intracranial hypertension. Whether we use hypotonic, isotonic, or hypertonic crystalloid depends on the situation. Most of the time we're thinking isotonic, and certainly when it's resuscitation, isotonic fluids. Hypotonic fluids may be used in maintenance situations to try to decrease the total amount of sodium being given. Hypertonic may be beneficial in resuscitation situations and or intracranial hypertension. Some data to support this, some data suggests it doesn't make much of a difference, so it's largely dependent on where you're practicing and what the local approach is. And then blood and blood products. Really, blood shouldn't be used as a resuscitative fluid. Blood and blood products should be used to treat a specific problem, related to bleeding and or extremely low hemoglobin, or to correct clotting factors in the face of bleeding, and so on and so forth. So let's think about what are, we're going to focus on crystalloid and think about what are in these solutions. So we start with the top column of kind of what's in serum, what we looked at before. These are sort of somewhere in the middle of the road for normal serum values for those parameters. And normal saline has quite a bit more sodium than normal serum, and an equal amount of chloride. And of course, no potassium, bicarb, calcium, or glucose. And its osmolarity is 308 with a pH of 5.6. That's an eye-opener for a lot of clinicians, that the pH of normal saline is quite low. And then, of course, half normal saline is exactly half that. So everything, cut it in half except for the pH remains the same. 3% saline, okay, so normal saline is 0.9%, so we can just do the math to multiply it out to see how much sodium and chloride, and of course the osmolarity is much higher, and the pH is even a little bit lower now. So this is typically used either in small amounts as an infusion to treat hyponatremia, or small boluses as part of a resuscitative strategy, and the hypertonicity of it is thought to increase the intravascular volume by a large amount. And of course, D5 half, same thing as half normal saline, plus a little bit of glucose, and that has the expected effect on osmolarity, and the pH drops even further. D5, so now just take out the normal saline and see what happens to the osmolarity and the pH there. And now Ringer's lactate, so a little bit lower sodium content, similar chloride content to serum, but lower than normal saline. Potassium's at 4. There's no bicarb in it because that doesn't stay in solution very easily at normal temperatures and pressures, so it's replaced with lactate. That's why it's Ringer's lactate. That lactate will stay in solution and then get converted into bicarb by the liver. A little bit of calcium, no glucose, slightly hypotonic, and although it is acidic, it's less acidic than normal saline. And then plasmolite is the other balanced crystalloid, and it's basically designed like Ringer's to look like serum, only instead of lactate, it's got some different anions to normalize the pH. So we say the sodium, potassium, chloride are kind of where to expect it. Now it's mostly acetate with no calcium, no glucose. So now you've got a normal osmolarity and a normal pH. A lot of studies looking at Ringer's or normal saline versus plasmolite, and no difference in outcomes, but plasmolite's just more expensive, so we tend not to use that as much anymore. And a recent study out of Nashville comparing normal saline to either Ringer's or plasmolite showed that the balanced solutions, Ringer's and plasmolite, had decreased mortality and decreased renal dysfunction. And a lot of this probably has to do with the pH and the chloride load. So that low pH of normal saline coupled with the high chloride load can cause or potentiate a pre-existing acidosis. All right, now how to use these fluids. And so when writing IV fluid orders, I like to think about the 5 R's. What are we using these fluids for? Is it for routine maintenance? Are we replacing some losses? Is there some redistribution going on? Are we resuscitating the patient? Or is it we've already started the fluids and now we're reassessing? And this busy algorithm is from the National Institute for Healthcare Excellence from England. It's a very useful clinical guideline that will kind of go down each branch of this, but it helps provide some thought process around how much fluid and what sort of fluid should you be using based on which of the 5 R's are you addressing. So we'll start out with the assessment. Okay, so basically, the initial typical assessment for somebody is ABCs, and then addressing those things in the order of priority. So once you've gotten past A and B and now you're on circulation, what do you think about their fluid status? And what do you think their fluid and electrolyte needs are? Okay, so then can the patient meet their own fluid and electrolyte needs? If the answer is yes, then it's just enteral nutrition support. Okay. If no, then you got to figure out, okay, what kind of fluid and electrolyte needs do I have to help guide me towards, is it replacement and redistribution or routine maintenance? All right, so really about what's their volume status? Are we in a fluid resuscitation mode? Are they bleeding, which sends us to fluid resuscitation? Is it sepsis, which sends us down fluid resuscitation and potentially replacement and redistribution? Same thing with GI losses. Could be fluid resuscitation, could send you down replacement and redistribution. And then if they have any renal function issues, how's that going to alter your thinking about both fluids and electrolytes? So we'll start with a case. Patient's a 59-year-old gentleman without any huge significant chronic problems who came to the hospital with acute cholecystitis. And so now he's going to be kept NPO. Vital signs are pretty unremarkable. Normal heart rate, normal blood pressure, normal respiratory rate. His oxygen saturations are satisfactory on room air, and he has a normal temperature. And his height and weight are as seen. So what kind of fluid IV orders are we thinking about? So where do we think we are? Are we in resuscitation mode with this patient? No, it doesn't sound like it. He seems like he's in pretty good shape. Are we replacing anything? There's no evidence and no history of any fluid losses or fluid shifts. So it was really in a routine maintenance mode for this patient. So what other things do we need to consider? What are we trying to maintain? Well, he's just being kept NPO, so it's just basic fluid needs and sodium and potassium needs. So thinking about those insensible losses and what are we trying to maintain? So some water, sodium, potassium, and potentially glucose homeostasis. So you go down that routine. IV fluids. So basically, 25 to 30 milliliters per kilogram per day of water. And a couple of different calculations that you can turn to figure out what's the ongoing maintenance rate. But 4-2-1 is sort of a typical rate. 4 milliliters per kilogram for the first 10 kilos, 2 milliliters per kilogram for the next 10 kilos, and 1 milliliter per kilogram for any remaining kilograms of total body weight. Sodium loss, sodium of about 1 to 2 milliequivalents per kilo per day, potassium about half that. The glucose isn't so much a replacement, but it's based on some old nutrition studies that show when you're fasting, that when you utilize all of your glycogen stores, then you'll begin breaking down muscle. And so by the administration of 50 to 100 grams per day of exogenous glucose in the fasting state will help mitigate that muscle loss. All right. So we'd start this patient on some basic maintenance IV fluids, and then stop the fluids when they're no longer needed, when the patient's diet is advanced again. Okay, again, there's that Holiday-Sicard nomogram to assess your maintenance fluid rate. So again, 100 per kilo per day or 4 per kilo per hour for the first 10 kilos, and then 50 or 2 per kilo per hour, and then 20 per day or 1 per kilo per hour. And so for our 80 kilogram patient, plug in the numbers, and I need about 120 milliliters per hour maintenance rate. Right. And then what fluid to use? Well, to get that 1 to 2 milliequivalents per kilo per day of sodium and 0.5 to 1 milliequivalents per kilo per day of potassium, D5 half plus 20 of K is pretty much in the ballpark. All right. Now, one thing about half normal saline is it still delivers more sodium than what you'd expect a patient to need. Really, quarter or fifth normal saline meets those insensible sodium losses, but it's pretty hypotonic. In most adult centers, we use half normal saline with the thought that we shouldn't be using maintenance fluids for day after day after day after day. And if their kidneys are fine, then they'll be able to handle that sodium load because it's not too excessive. All right. Then don't forget about other sources of fluid and electrolytes, depending on what IV fluids, what IV medications we're giving. Sometimes if the patient's getting multiple antibiotics plus other IV medications, that the total volume and sodium load can creep up on you if you're not paying attention to it. All right, case 2. We had a patient, a 64-year-old lady who's 110 kilos, who's in for a small bowel obstruction, and she's got an NG in, and the NG is putting in about 3 liters per day. But her renal function is satisfactory, and her daily labs aren't really changing with any significance. So, is this patient in resuscitation mode? No. Are they in replacement redistribution mode? Yes. Do they also have a routine maintenance component to it? Yeah, sure. So we have to start thinking about it a little bit differently, but it's primarily the replacement redistribution. It's that 3 liters per day of NG tube output that we really are addressing with our IV fluid orders. So this is where limb of the algorithm gets a little bit more complicated depending on what you're replacing. And so really thinking about, what part of the GI tract are we losing fluid from? Or is it, and do we have urinary losses or other insensible losses to account for? So in this particular case, it's NG output. So it's, it's gastric fluid, and then possibly biliary and pancreatic fluid as well. But primarily it's going to be gastric fluid. And so you just think about, well, what does that mean as far as sodium and potassium losses? Compare that with pancreatic or jejunal losses. If you had, say, a pancreatico-cutaneous fistula or a jejunal ostomy that had high output, then it's going to really change your thoughts on what do I need to do with my electrolytes. But really thinking about where are your GI losses coming from, and then adjusting accordingly is the key thing to remember here. So we start with our existing fluid electrolyte status, and in this patient we said vital signs are normal, and their metabolic panel is normal, so they don't have any major abnormalities regarding intravascular volume or electrolytes. So it's really centered around the ongoing losses from that NG tube, and then just account for that. So we've got your typical insensible losses plus the NG tube volume loss, and then prescribing your fluid order to address that. So what do you want to, again, it's a lot of sodium losses from gastric output, so probably something like normal saline or lactated ringers rather than half normal saline. Plus some additional potassium to account for those potassium losses from the stomach. Whether or not you add D5 to it is, again, debatable, but some people would suggest that that exogenous glucose to reduce muscle wasting. And then what rate are you going to order? Well, it depends on access and timing of other medications, but again, taking that total daily volume loss and dividing it by 24 to give you your hourly rate. Now, this is patient, you're going to need to assess more frequently, because depending on what's happening with that bowel obstruction and that NG output, you want to stay on top of that. You don't want to wait 24 hours to realize that the NG output dropped down to nothing, but you're still giving fluids to replace it. So this is going to require more frequent assessment. All right, the third patient is a 78-year-old demented nursing home patient who was brought to the ED for acute mental status changes and fever. They got slightly elevated temperature, they're tachycardic, their blood pressure is a little low, and they're tachypnic. Height and weight are pretty normal. UA shows some elevated white blood cells and a leukoesterase in the urine. They have a mild leukocytosis, and the BUN creatinine is 58.1.3, which is elevated compared to this patient's normal baseline, and their lactate's up. So what's our initial fluid orders here? So where are we with this patient? And is it resuscitation? Yeah, it sounds like sepsis. And with an elevated lactate, I think we're in a resuscitation mode. And there certainly wasn't any history given of any significant losses. And because we're in resuscitation mode, we know we're not in routine maintenance. So resuscitation is the name of the game for this patient. So looking down the resuscitation arm of the algorithm, and it's, identify the cause, in this case sepsis, and respond. So minimum of 500 cc bolus to start with, and in accordance with the surviving sepsis guidelines, we'll be giving a 30 per kilo bolus within the first 3 hours, and then reassess. So whether you ordered it as a 30 per kilo bolus right off the bat and then reassess, or for some reason you want to be cautious about your fluid resuscitation and you want to give it in smaller increments, but then reassess more frequently and then follow it up with the next bolus, either way is useful as long as you get that 30 per kilo bolus within the first 3 hours. So it's all about, just like any other resuscitation mode, it's assess, reassess, reassess. So you give that initial bolus, then reassess the patient, both a physical exam and recheck that lactate, and decide, do they still need more fluids? And you're still in the resuscitation mode, and you just kind of keep going around that circle in a loop. And if the signs of hypoperfusion are improving, and you've got adequate parameters of adequacy of your resuscitation, then you can start de-escalating the fluid boluses. At that point in your reassessment, then you have to decide, am I going to continue fluids because of any ongoing losses or a maintenance mode or not? So fluids for this one is crystalloid, and again, a minimum 500 cc bolus. Whether it's normal saline or lactated ringers, the evolving evidence on this, based primarily on a large study done published in 2018 from the Nashville group, suggests that lactated ringers would be our preference here. Again, minimum 500 cc bolus, and you got to give it fast. This is something that you have to be very specific with your team as to how fast do you think a bolus is, because if you just say wide open, you'll get a wide range of opinions on what wide open means, and based on the experience of your nursing staff primarily, is very frequently the interpretation of wide open means put the IV tubing on the pump and turn the pump up the fastest it'll go. And most pumps max out at around 1,000 or 1,200 cc's per hour. But that's too slow for somebody who's in resuscitation mode. And oftentimes you have to talk to the staff about using pressure bags in this situation. The route of access is also important. We'll talk more about this later in the lecture. But looking at your IV access, whether you've got a central line, what kind of central line, how large are those lumens, how long is the central line? If you've got peripherals, same deal, what size are those? And making a proactive assessment on which IV access should you be using. Because the length of the IV tubing and the diameter has a big impact on how fast you can give it. And in many central lines, if you use that blue port or that white port, because of the length of the central line, even on a pressure bag, it might take you over an hour to get that liter of fluid in. So you have to specify that it's the distal port, or if you've got peripheral, that peripheral IV might actually be preferable to the central line for giving a fast fluid bolus. Okay. So we gave that initial IV fluid bolus, and upon reevaluation, we see, well, their mental status is a little bit better. Their heart rates come down a bit. They're still hypotensive. Their respiratory rates improved a bit. Their lactates come down a bit, but it's still elevated. So what do we do now? And they're still in resuscitation mode. So it's give that next bolus. And again, in sepsis, that initial goal is up to 30 per kilo. And that's just the initial. You still reassess at that point. And if there's still evidence of hypovolemia and hypoperfusion, then you might continue giving fluid boluses beyond that 30 per kilo. If they're still hypotensive, but you have evidence to suggest that their intravascular volume is satisfactory at that point, then you might start backing off the fluids and shifting towards using pressors to reestablish some appropriate vascular tone. All right, so the next one. I have a little old lady who fell at home. She has a little subdural hemorrhage and was admitted to the ICU for close monitoring and serial neurochecks, but has no other injuries. She's just being kept NPO in case she deteriorates and would require urgent surgical intervention. And so what IV fluids ordered do we want for this patient? So this is a little bit of a tricky one. It's a routine maintenance. She doesn't have any ongoing losses. She's not bleeding. She doesn't have GI losses. We're just keeping her NPO, so it's routine maintenance. However, she has the intracranial injury. So this is one where rather than using the hypotonic saline to address those insensible sodium losses, we'd probably use an isotonic normal saline or possibly even a hypertonic saline to maintain the high normal or even supernormal serum sodiums. All right, this next one, patient's 56-year-old gentleman with prolonged alcohol abuse who was dropped off from the ED by his Uber driver because he threw up a bunch of blood in the back seat. And he's tachycardic, hypotensive, or at least borderline blood pressure, tachypnic, and hypothermic. Had a little bit of a leukocytosis, and his hemoglobin's 6, and his platelets are a little low too. Metabolic panel is, as shows, a little bit hyponatremic and hypokalemic and hypocalcemic, and he's got some elevated BUN, presumably due to his GI bleed. So what kind of fluids does this guy need? Well, he's in resuscitation mode. What kind of fluid do we want to use for him? So typically, as we said before, is crystalloid, but this guy's a GI bleed. So what do we want to use for his IV fluids? Well, he's going to be blood transfusion first, and then once you've adequately addressed the source of blood loss, he's gotten his EGD, and we've stopped the bleeding, or he's gotten his TIPS or whatever other intervention to stop his bleeding. On the ongoing reassessments for the resuscitation, once you're happy that the bleeding stopped and you have a reasonable hemoglobin, so at least above 7, then if he still requires some resuscitation, then you would switch to crystalloid at that point. All right, here's another case, a 38-year-old lady who just returned from a trip to Mexico and got sick on the plane, and then over the next week has had some ongoing GI losses. So she came in to be seen, and her labs show that he's hyponatremic, hypokalemic, and on exam, she's clearly hypovolemic. So what kind of fluids do we want for this patient? So she's a replacement and redistribution. She's got those ongoing GI losses, and we need to account for those. So we've got evidence of dehydration, so we have to kind of think about that as to how much fluid do we need to give her to make up for what she's lost, and then how much additional fluid and what electrolyte content do we need to give her to account for her ongoing GI losses, and what kind of GI losses are they? And the reassessment for this patient is going to be daily at least, probably more than once a day potentially, but she needs to be reassessed fairly frequently. All right, this next case, a lady with diabetes that she's had since the age of 20, and she comes in with nausea, vomiting, abdominal pain. That all started with an upper respiratory problem that she had a few days prior, and her blood sugar has been kind of creeping up. And then as this has all progressed, she's not been able to take much food in, and so as a result, she's been taking her insulin pretty inconsistently. So heart rate is a little tachycardic, blood pressure is satisfactory, she's a little tachypnic, normal temperature, and physical exam suggests she's a little hypovolemic. She's hyponatremic, potassium's a little elevated, and her blood sugars are extremely elevated, and the ketones and beta hydroxybutyrate confirm that she is in DKA. So what are the initial fluid orders? So this is mostly a redistribution due to the DKA. Okay. All right. So again, thinking about what are her redistribution needs. Does she have any other ongoing losses? She had some nausea, vomiting. So do we need to account for that? And treat the acidosis. So the main treatment for diabetic ketoacidosis, give her plenty of IV fluid. So give her, so in some ways, this is almost like a replacement/resuscitation mode. Replace those fluids, the acidosis will correct itself, and treat the hyperglycemia to take care of the underlying problem with typically an insulin infusion. All right, so this is just an algorithm for taking care of patients with a diabetic hyperglycemic crisis. There's a number of different algorithms out there that are all some variation of this. Most electronic health records have this built into the EHR now, so it can be ordered more easily, but if you don't have it in the electronic health record, it's easy enough to pull up online. But again, the IV fluids, it's treating that hypovolemia and paying attention to the serum sodium and potassium, with note that as you're giving the insulin, to deal with the hyperglycemia, the insulin's going to drive the potassium intracellularly. And so expect that serum potassium to drop as your ongoing fluid replacement continues. All right, now just a little bit about just electrolyte replacement in general. Very little data on this. So most of this is just using some common sense and deciding how much you're going to give and how often you're going to reassess the patient based on where the starting point is. So if you're replacing potassium, it can be given orally or intravenously. You need to think about what sort of IV access you've got, because if you're giving IV potassium through a peripheral vein, that can be pretty uncomfortable. So whenever possible, you try to give it orally. There's also some thought that you'll actually, if you've got a functional GI tract, that you'll absorb the PO potassium faster than you can infuse it through an IV. The serum potassium may be expected to increase by about 0.25 milliequivalents per liter for every 20 milliequivalents given, but that is quite variable because depending on what the underlying problem is and what their total body potassium is, all that potassium that's intracellular, your serum potassium may correct at very different rates. So when you need to just be cautious about that, particularly if they have any chronic or acute kidney dysfunction. We just need to slow things down and check, give smaller aliquots and check more frequently. Particularly when the patient is severely hyponatremic or can be hypokalemic, you need to consider their magnesium level and check that and just replace that as well. Hypomagnesemia can really potentiate a significant hypokalemia and hypocalcemia. And of course, look at the EKG to assess for EKG changes associated with hypokalemia. Same thing with replacing the calcium. You can give it IV or oral. If I'm giving calcium as just a replacement for hypocalcemia, I'll typically give it orally. If I'm giving calcium for the purposes of achieving vasoconstriction or increased cardiac output, increased contractility, then I'll give it as an IV bolus or a push. And if it's as a push, then it needs to be a slow push through a central access. Similarly, just recheck it as often as you clinically feel like you need to, based on how low it was to start with and how much you're giving. As with potassium, if you're treating hypocalcemia, think about the magnesium and that look for any concurrent depletions. So magnesium, once again, can be given orally or IV. Typically, if the GI tract is available and working, then just give it orally. Certainly, for significant hypomagnesemia, you might give a combination of oral and IV concurrently. If you're treating hypomagnesemia, that's one thing, but if you're treating arrhythmias, then you're going to be more likely to use the IV route. All right, and then for phosphorus, we think about this primarily with patients who are malnourished and or trying to wean from the ventilator. So it's one we may or may not check routinely, but certainly hypophosphatemia is associated with failed extubation. And patients who are suffering from refeeding syndrome, you can see precipitous drops in their serum phosphorus. So just like the others, IV or oral repletion, and the amount and route is really kind of up to the prescriber. So that is pretty much it with electrolyte replacement. So let's talk about IV access for a bit, the different types of access. So peripheral versus central venous, and with central venous, you've got tunneled versus non-tunneled, with or without an implanted subcutaneous port. And then you got kind of the in-between the central line and the peripherally inserted central catheter. So it is a central line, but it's being placed through a peripheral vein. And then the midline is the in-between. It's going through a peripheral vein. It's longer than a peripheral IV, but it's shorter than a PICC line. Typically, if it's being put in the upper arm, the tip of it's terminating in the axillary vein. Midlines usually are used for kind of intermediate term use, so a few days, maybe even a week or two, or some places it'll be longer, but the DVT risk is higher than it is with central lines. So oftentimes we'll use these when we think we don't need it for real long, but we need it more than a couple of days, and especially if they're difficult peripheral IV access. Dialysis access is similar to central venous access as far as temporary access devices, so tunneled versus non-tunneled, and then fistulas and grafts for the longer term access. The subcutaneous route is a possibility, and it's something that's oftentimes overlooked. But when you've got a patient who just needs some maintenance fluids to treat some hypovolemia because of poor PO intake, they're just dehydrated, and it's tough to find a vein on them, and you're poking them, know that you can do hypodermoclysis, where you just put usually a butterfly catheter terminating in the subcutaneous tissue, and you can give 60 cc's an hour through that. You can even do multiple sites where you could have 3 or 4 of them going to give more IV fluids. And this is used especially like say a nursing home patient that has poor PO intake, and you just need to get some fluids in them to wake them up. If you have trouble placing a peripheral, then consider using the subcutaneous route. Again, this is really just for maintenance fluids and nothing else. And then intraosseous that's the nice bailout where you can't get peripherals for whatever reason. You can't get central venous access. You need something really fast. Intraosseous is a nice short term, and typically 24 hours or less to give fluids, and medications can be given through them. So really the decision between peripheral versus central access when we're talking about IV fluid resuscitation, as mentioned before, it's the length and diameter of the tubing that are primary concerns. Viscosity also affects it, but it's really not something that we have to worry about as far as this goes. But the length and diameter of the tubing suggests that your peripheral IV might be preferential access point compared to your central line because it is so short. So you'll see some variability on exactly what the max flow rates are because there's so many different products out there. But for the typical 7 French 20 centimeter central line, where the distal port is a 16 gauge catheter, because of the length of it, it's going to take you a little over 20 minutes in most lines to get that liter of fluid in, where even a 20 gauge peripheral IV, you might be able to get that liter in less than 20 minutes. So for me, it's just a discussion with the nursing staff over what choices do we have for access and which one are we going to use. If the patient's got a PICC line, again, because that line is so long, it's hard to push the fluid fast through that. Now, certainly if that's all you've got, that's what you're going to use. And if you've got multiple lumens, whether it's a central line or a PICC line, and you want to get fluid in faster, you could potentially start multiple boluses and use all the lumens that you've got available. Again, the specific flow rates and maximum infusion rates vary, but most manufacturers, both peripheral and central venous catheters, will print these max flow rates on the packaging. So that's it for some basic fluids and electrolytes. I appreciate your attention on this and hope you found it helpful. Thank you very much.